But we do know a lot of things that work in post-Lyme syndrome. And there's a lot of things that don't work. So I'm going to focus as best I can on what does work. We really need to make sure that your Lyme patient is a Lyme patient. I use C3A and C4A. We've talked about that. There's a question earlier from John, and this question is, if you have defective antigen presentation, is there going to be reliance that is merited on an antibody test? And it's a reasonable question to ask. We know that where people fail in management of post-Lyme syndrome is that antibiotics will never fix MSH and VIP deficiency. Antibiotics will not fix T regulatory cell physiology in those with HLA susceptibility to post-Lyme syndrome. We also have got to deal with an assumption, there's that word again, that once Lyme disease, always Lyme disease. Lyme, when it's there, will change the host such that as time goes by, HLA susceptibility to other illnesses will be expressed, and if they had Lyme last year and they was treated successfully, a year later they get sick again, do not assume that this is a cyst phase. Do not assume that this is a co-infection that was latent. Be looking again as if this were a new illness. It probably will be. The other thing I need to ponder is that I have little spots on my lung, on my chest x-ray, and I test positive to a skin test for mycobacteria battii. And I have these atypical mycobacteria that are alive, and they're in me. Do I have atypical mycobacteria pneumonia because I have these granulomata in my chest? No, I don't. And if we see a spirochete inside of a fibroblast, does that mean that that person is affected with Lyme? I actually don't think so. Could there be sequestration of living Lyme organisms within tissue like the granulomata? I think that may be the truth. We know the final common pathway here for post-Lyme is exactly the same as what it is in other biotoxin illnesses. There's very few changes. You'll get visual contrast test positivity that's no different from dinoflagellate patients and from mold patients. The biotoxin pathway slide that has been modified to show you what we have now is an update from this particular slide, but I did want to tell you about 150 patients that I looked at last year who had confirmed Lyme showing either a definitive ECM rash. There's 60% of those were in this 150. 32% of my patients were Western blot positive from LabCorp or from Quest with IgG. And interestingly, 74% were positive with IgM. In my area, there aren't too many docs that treat acute Lyme, and most people kind of know who I am, so I get a disproportionate crowd of acute Lyme patients. What we look at is data at baseline after 3 weeks of oral antibiotics and then after biotoxin treatment for these patients. Differential diagnosis in each of these did not show any other explanation for acute or chronic symptoms. After antibiotics, and it usually was doxycycline for women, either doxy or amoxicillin for men. I use very little amoxicillin in women. It's kind of an abusive thing to say, here's your yeast problem. Nonetheless, that's just my personal approach to use of antibiotics, and there were a few people I used Biotoxin and a few people I used Ceftin. At any rate, after 30 days, actually extra 3 weeks of antibiotics, their labs are collected, and if they are not 100% fine, and they would not be included if they were all fixed, this is the post-Lyme syndrome, then they were given run-up with Actos in the no amylose diet if their leptin is greater than 7, or the fish oil if their leptin is less than 7. Don't forget, Actos lowers leptin, leptin drives MSH, so if you take your leptin less than 7 and reduce it down to about 2, which is what you do with Actos, you reduce MSH production tremendously. So make sure leptin is over 7, otherwise use the high-dose omega-3 fatty acids. The run-up of diet and drug for 5 days, and then start cholestyramine at full dose, a scoop 4 times a day, after the run-up is done. If they've got Marcons present, they are eradicated. The protocol we've talked about is Bexspray and rifampin. We are going to be treating ADH and osmolality, PI1, gliadins, androgens, all the things wrong.